everybody that
Okay, everyone else is muted.
Okay.
Levy. Yeah.
Okay, very good. Will we proceed?
Yes, please.
Thank you.
Okay. So the important point here is, in a lot of diseases, it's sort of natural. Let's say if you have Alzheimer's, or you have chronic fatigue, or you have hepatitis or an infectious disease, any sort of disease, to think that in the cells, in the affected tissues, they have some sort of unique disease process going on that makes it a cell in Alzheimer's or a cell in chronic fatigue. That's not the case. There is no such thing as a disease cell that's unique to that disease, except to the degree that a given disease has a unique array of biomolecules that are oxidized, a unique degree to which those biomolecules are concentrated, where they're located, how long they've been oxidized. And that's it in a nutshell. Now, when you've had some arrays of biomolecules oxidized for a long period of time, you can start to get secondary physical degeneration of tissue, but it's still the oxidation that started the process and worsened the process, so that somewhere down the road your tissue no longer appears normal because it's been oxidized in various biomolecules for such an extended period of time. And this is why different toxins produce different diseases. The solubility sends a toxin in one direction, the physical size another. Whether it's ionically charged or neutral determines its access, intracellular, extracellular. Some toxins impair by physically imitating other structural molecules, and some toxins are uniquely situated so that they oxidize more selectively specific enzymes. So, and you can imagine if you inhibit one enzyme with a toxin of a unique chemical configuration, that's going to produce an entirely different syndrome from another toxin. Probably one of the best examples too is a toxin can kill you in a minute, and a toxin can kill you in 20 years. And again, it all depends on where it goes and what it oxidizes. If you inhale cyanide, it gets rapidly, because of its physical configuration and unique chemical structure, it gets rapidly taken up in the lungs and specifically goes and starts to poison or oxidize respiratory enzymes that allow oxygen to be incorporated into the Krebs cycle, which means then that with cyanide present in only a minute or two, you effectively deprive your body of oxygen and you die. On the other hand, you can take something like mercury, which large enough can have an acute effect too, but most commonly, mercury in most people comes from their mercury fillings, and they do fine for 10, 20, 30, 40 years until the mercury accumulates to a point in their brain where you start to see diseases such as multiple sclerosis. So again, the damage is all the same. It's oxidation. It just depends on where it occurs, how quickly it occurs. And as we mentioned last week, or a few weeks ago, anything that prominently promotes oxidation is going to prominently promote chronic degenerative disease. So as I mentioned, the number one source of disease-causing agents, better known as toxins, better known as pro-oxidants, are infections. Endotoxins, exotoxins, the metabolic byproducts. Also, very important, iron, okay? All pathogens proliferate due to the presence of iron. The more iron you have around for the infectious organisms to take up, the more they proliferate, which also means that when you start killing an infection and killing the pathogen, you start releasing a large amount of iron, which is basically another toxin. So infections produce these toxins, and when you cure or resolve the infections, you can get an acute release of toxicity. Something we'll mention a little later on today, but not as much detail as we did last time, is chronic pathogen colonization. When you have pathogens present, they can manifest as a body-wide disease, or they can manifest as a very concentrated area, such as an abscess, and probably most commonly, but very little discussed, is they can colonize. They're not really proliferating to make an abscess. They're not disseminating throughout the body, but they're in a certain area of your body, much like what's called a focal infection, but less concentrated. A focal infection, as I said, can manifest as an abscess, an infected tooth, infected tonsils. Chronic pathogen colonization is something where you don't feel acutely infected, you don't look acutely infected, histologically you're not acutely infected, but pathogens are continuing to slowly grow and proliferate, and they're characteristically covered by biofilms so that they're persistent. This is very common and almost the rule, not the exception. After you've had a cold or flu, which severely affects your upper respiratory tract, oropharynx, and nasopharynx, once you've resolved the acute pathogen that caused that syndrome, you've had a derangement of the normal flora in your upper respiratory tract, and that tends to persist. And unless you take specific interventions to eradicate the biofilm covering this chronic pathogen colonization, you will keep a chronic pathogen colonization there basically for the rest of your life. And this, in my opinion, is the primary reason for leaky gut syndrome and an abnormal microbiome in your gut causing the leaky gut syndrome. When you have the chronic pathogen colonization, what are you doing 24/7? You're swallowing pathogens and you're swallowing the toxins that they produce. And this really gives you the entire variety of gut-related diseases. And of course, once the gut is deranged, then you develop the other diseases. We see lots of evidence now on Alzheimer's, neurologic diseases, all being promoted by not only the abnormal toxins that get absorbed through a leaky gut, but sometimes the pathogens themselves. So you have known exogenous toxin exposures, as I mentioned, not only toxic iron coming from pathogens, but in your food and in supplements. Never supplement iron unless you have an established iron deficiency anemia. And never have an iron deficiency anemia unless you've had an evaluation to make sure that you're not bleeding somewhere, as with a new diagnosis cancer. Dietary toxins, very important, and hormone imbalances, very important. I should say, rather than imbalances, deficiencies. Sex hormones, cortisol, thyroid, especially sex and the thyroid hormones, when these are only slightly below normal and oftentimes in just the low normal range, this causes a tremendous increase in body-wide oxidative stress. Okay. All right, with that as the baseline, there are several things that magnesium works in coordination with to regulate the levels of oxidative stress inside the cells. And as I mentioned earlier, all disease is associated with and caused by, associated with and caused by increased intracellular oxidative stress, increased IOS. Quite simply, if there's no increased intracellular oxidative stress, there is no disease or pathology, which also means that if you can find ways to directly impact and lower increased oxidative stress, you will progressively improve that disease or resolve that infection all the way to the point of complete resolution or complete cure if you can take the measures necessary to completely normalize and bring back to the physiological range the intracellular oxidative stress. And so the primary regulators of this are intracellular calcium, magnesium, vitamin C, glutathione. Calcium is the biggie, and because of the relationship of calcium and magnesium, this is what makes magnesium so incredibly important and incredibly therapeutic. In my book, Death by Calcium, I go over this in greater detail. You can see all the references that are in the literature, and there are an enormous number of them. But the first sentence is very important. The intracellular calcium concentration is the primary determinant or cause and marker of increased intracellular oxidative stress. The higher it is, the greater the oxidative stress. When it's normal, there's no longer oxidative stress. Because of this then, and this comes into therapeutics, because of this then, the manipulation of intracellular calcium levels appears to be the most straightforward and most reliable way to positively impact or lower increased intracellular oxidative stress and thereby positively impact all disease processes and all infections. We know, and this goes along with this concept, that the more calcium you take in by supplements, the more calcium you take in by diet, this in fact dramatically increases all-cause mortality. By itself, calcium supplementation has been shown to increase your risk of heart attack. Calcium, along with copper and iron, are what I call your three toxic nutrients. They're absolutely required at low levels to support good health and support normal intracellular and extracellular metabolic functions, but only a low level. Above that, it actually turns out that these three nutrients/toxins are actually the primary players in increasing intracellular oxidative stress to the point that either cancer develops, a chronic degenerative disease, or when it gets very high enough, the cell goes into apoptosis or frankly ruptures in a necrotic fashion and dies. So basically, it's kind of perhaps ironic to say it this way, but calcium, iron, and copper are essential for cell life, and above a certain level, they're essential for cell death. And that's why, of course, it's so important not to go unrestrained in supplementing these substances. Virtually, calcium should never be supplemented. Copper as well. There's a lot of copper in supplements. In my opinion, it shouldn't be there because I have yet to see any evidence of any person on the planet being copper deficient. You only need extremely tiny amounts of copper for the functions that it supports in the body. So you need, and the only time you would take iron is when you have an iron deficiency anemia. So except for the iron deficiency anemia, you should never take iron, and basically for calcium and copper, just never at all. Okay, now we can start to see now where magnesium has its enormous role. I just told you that calcium basically is the common denominator in causing and worsening all diseases because it's the primary regulator of intracellular oxidative stress. And when that intracellular oxidative stress gets elevated, you've got a quote unquote disease cell because there's so many different biomolecules that have been oxidized. Well, as it turns out, magnesium is a natural calcium channel blocker. A calcium channel is basically a protein that lays across the cell wall and facilitates the influx of calcium into the cell, okay, which is important in keeping the cell calcium levels from getting too high. And the way you decrease that is there are a lot of different agents, including pharmaceutical agents, calcium channel blockers, that slow, inhibit, or stop the new calcium intake. Now, magnesium is a natural blocker and a natural calcium metabolism antagonist, not just the intake of calcium into the cell, but also antagonizing its functions. And just like the increased oxidative stress seen with higher levels of calcium, the more calcium you have present inside the cell, the more you have an abnormally elevated level of calcium metabolism functions that cause pathology, and magnesium opposes that as well. So what I would submit to you is this, if you will, anti-calcium property of magnesium, I think is the single most important property of magnesium in terms of its enormous positive health impact throughout the body. Calcium makes all the cells sick. Magnesium and getting calcium out and preventing it from coming in makes all the cells well. It's simplistic, but it really is that simple. And in the yin and yang of calcium and magnesium, just as calcium increases all-cause mortality, more magnesium decreases all-cause mortality. These are the references. Vitamin C is sort of actually a secondary player in terms of intracellular oxidative stress. The more you can get vitamin C inside the cell in its reduced state, the less intracellular oxidative stress. The only problem is a lot of vitamin C enters the cell through the vitamin C transporters, the vitamin C transporters, which only takes vitamin C in its oxidized state, and then it needs to be reduced to be active inside the cell. Well, if your magnesium levels are low and your calcium levels are high, when you bring the oxidized vitamin C inside the cell, it never gets reduced. So it's only when you can start getting vitamin C levels that are reduced inside the cell in increased concentration that this impacts. A good way to look at this too is whenever intracellular oxidative stress is elevated, severely and chronically, you can quite comfortably say that you have a state of focal intracellular oxidative scurvy, focal intracellular scurvy. Glutathione is important, but it's the laggard. It comes behind. You're never going to get your glutathione levels up when the calcium, magnesium, and vitamin C are out of whack. That's because as long as those other three are out of whack, there will be increased intracellular oxidative stress, and this directly impairs and oxidizes the glutathione synthesizing enzymes inside the cell. When they're oxidized, they don't work, and when they don't work, you can't synthesize glutathione. So you can only start to really get healthy levels of glutathione inside your cells when these other three important parameters have normalized or are strongly going in a normalizing direction. You know, you can overwhelm this to a certain degree. You know, you have intravenous glutathione and liposomal glutathione, and these can be positive counteracting factors, but you're never going to keep a sustained normal level of glutathione inside any cell as long as the calcium, magnesium, and vitamin C levels are suboptimal. Now, let's go a little bit more now with all that background information as to the characteristic and role of magnesium. Because of its impact on vitamin C and glutathione, you can actually really say that there's no single molecule more critical for sustaining health and sustaining life and promoting health. You're only going to have the vitamin C that you need to sustain health if the magnesium is in good shape as well. This is why I like to say, and I think everybody knows, that there's probably nobody more enthusiastic about vitamin C and its role in the body than me. But as a point of emphasis, if somebody said, what is the single most important supplement to take? If you could take one and not any others, it would probably be magnesium, because magnesium allows other antioxidants to stay reduced and keep reduced what levels of vitamin C that you have. Whereas with vitamin C, if you don't take vitamin C, but you have other antioxidants, they can compensate. Nothing can compensate for a magnesium deficiency other than magnesium. If you're deficient in vitamin C, then you're deficient in antioxidant capacity, and other antioxidants can partially compensate for the vitamin C deficiency. Nothing compensates for magnesium deficiency other than magnesium. A few facts: it's the second most abundant intracellular cation behind potassium. It's present in very high concentrations in all cells. This is important that we appreciate. It's an essential cofactor for hundreds of critical enzymes. And perhaps even more impressively, enzymes aside, it's involved in roughly 80% of all known and identified metabolic functions in the body. And as far as an energy molecule, as Dr. Selvin was mentioning earlier, nothing could be more critical to having a normal energy status in the body, normal levels of energy in the mitochondria, where in fact magnesium is highly concentrated. It's a critical factor in ATP, that big energy molecule, and glutathione synthesis. And finally, we're seeing, of course, probably even more and more during this COVID pandemic, as more and more research seems to be getting done rapidly and published rapidly, more than I've ever seen in my life. There's a lot of evidence now that one of the main factors to staying healthy, avoiding COVID, and getting over COVID more quickly and without dying is maintaining healthy and elevated and even slightly elevated levels of vitamin D. Well, turns out little old magnesium again is needed to convert vitamin D to its active form. So all these things, as I mentioned earlier and Dr. Selva mentioned earlier, have all ongoing interdynamic relationships, and once again underlies the concept that you really can't think of these things in isolation. You always have to think about how one thing is affecting another. Is it suppressing one thing and supporting another, having no impact? All these things need to be answered and understood to continue to evolve an optimal treatment protocol. Now, turns out a total body magnesium deficiency is extremely common. I think you'll see stuff in the literature that says 60%, 70%. I think, based on some of the information I'm going to give you in subsequent slides, I think the vast majority of the population, especially the older population, okay, is minimally to severely deficient in magnesium. What I mean by nearly most, I mean, in my opinion, now this is my opinion, I think well over 90% of the world's population is significantly magnesium deficient, and 90% plus have at least a minimal amount of magnesium deficiency. In other words, I consider a magnesium replete or a normal status magnesium person to be, as the old proverb goes, as rare as a hen's tooth. Now, if you're deficient, you need supplementation, because you're deficient because your lifestyle and your diet is not cutting it. And dietary intake, while can be supportive of keeping your magnesium levels normal, it will never maintain normal levels by itself. And finally, in this context, and not surprisingly from looking at the previous slides, it turns out that low magnesium levels do in fact and are the primary cause of many diseases, but even more importantly, a chronic magnesium deficiency promotes and accelerates the evolution and development of all known chronic degenerative diseases. Okay, examples: coronary disease, metabolic syndrome that leads up to the constellation of lipid abnormalities and blood sugar abnormalities and blood pressure abnormalities and obesity that leads to coronary disease is strongly impacted by magnesium. When you have metabolic syndrome and you start taking magnesium, you can see an incredible normalization direction, not absolute normalization, normalization direction in the metabolic syndrome associated blood work very rapidly. Chronic fatigue, osteoporosis, critical role. Anything that involves calcium deposition. All these x-rays and tests and everything that we do these days, CAT scans, and we see all these accumulations, bright spots of calcium on the study indicating usually rock-like depositions of calcium. All of these things are promoted by mild to severe magnesium deficiency. And because of that, when you start taking in large amounts of magnesium, you can very effectively, if you're doing it properly, start to redissolve those stones and resolve them. Depression and something else, I'll go into a little more detail, but migraines. Whenever you're thinking of diseases caused by magnesium deficiency, you need to think of the fact that the less magnesium you have, the more you are prone toward vasospasm, or an abnormally increased vascular tone due to an abnormally increased amount of tension in the vascular muscle. So conversely, magnesium is the primary way in which you relax that musculature, lower blood pressure, and decrease any condition which is characterized and worsened by vasospasm. Migraine, in my opinion, the evidence shows that migraine is primarily a magnesium deficiency condition. I can almost guarantee you, if you're having migraines, you're not anywhere close to having normal levels of magnesium inside your cells. So, sort of the recap then, magnesium as role of magnesium. Magnesium directly counters the toxicity of excess calcium. It dissolves old calcium deposits and prevents new ones. The higher the intracellular calcium, the sicker the cell. The higher the intracellular calcium, the lower the intracellular calcium, and the healthier the cell. It's a powerful calcium blocker, and we talked about the mortality studies. So, all positive clinical interventions should be directed at lowering calcium, which means increasing magnesium and avoiding calcium, of course. Now, a little data, statistical evidence that's not probably well appreciated is calcium is roughly 10,000 times more concentrated outside of the cell than inside. So even when you're talking about calcium excess inside the cell, you're talking about excesses that are above a fairly low level relative to outside amounts. But because of this, think about this, you have this intensely concentrated pool of calcium outside the cell, relatively tiny amount inside the cell, but this means you're going to have a non-stop pressure, if you will, for calcium to always try to get inside the cell. And for every calcium ion that gets inside the cell that is not needed, you have to expend energy to push that calcium outside the cell. So this is a major reason why this causes such increased oxidative stress is because it consumes so much energy. And when you consume energy, you take molecules from their reduced state to their oxidized state. So when you consume energy, you increase body-wide oxidative stress, and you increase especially intracellular oxidative stress. Now, magnesium, yin and yang, opposites, has basically the opposite concentrations. It's more or less 10,000-fold more concentrated inside the cell than it is outside the cell. So anything that pushes magnesium into the cell effectively pushes calcium out of the cell. Now, we know a lot of things that calcium causes as pathology. And it's good when you're looking at the literature to not only read in the literature that excess calcium causes this, but you could strike out excess calcium and read the same article as significant magnesium deficiency causes this. So it's the highest levels of intracellular calcium and the lowest levels of intracellular magnesium that ultimately result in cell death. Similarly, we talked about the pro-oxidant nature of all toxins. Well, pro-oxidant toxins do what? They oxidize biomolecules, and when that oxidative stress is up, you increase intracellular levels of calcium, you decrease intracellular levels of magnesium. Now, they haven't studied all the diseases, but in the ones that they've studied, in this case, ALS, Parkinson's, and Alzheimer's, always see elevated intracellular calcium levels. Now, a little bit about the calcium channels. Calcium channels, as I mentioned earlier, are literally proteins that lay across the full extent of the cell membrane so that one end of the protein is extracellular and the other end of the protein is intracellular. And by whatever unique biochemical characteristics it has, these channels are selectively permeable, selectively allowing calciums to enter the cell through these portals. Now you have pharmaceutical agents called calcium channel blockers, and you have natural agents like magnesium, and it's not the only natural agent, it's just probably the most potent one, a natural agent that's a calcium antagonist and a calcium channel blocker. Now, I mentioned before that decreased magnesium or increased calcium promotes increased vascular muscle tone or your tendency toward vasoconstriction and vasospasm. As you lower calcium and increase magnesium, this vascular tone goes down. This is often manifested as high blood pressure, but that's not the only manifestation. But because of this, calcium channel blockers were developed as an antihypertensive agent. Okay? And because of this characteristic, the only known significant side effect of most calcium channel blockers is that you block the calcium too much and eventually cause the magnesium effect to be too exaggerated, and then this goes in the opposite direction. It impairs vascular contraction and causes hypotension. And in fact, when you have somebody with a pharmacologic calcium channel blocker overdose or a magnesium overdose, guess what? You use the evil calcium to help counteract it and undo the acute toxicity of that calcium channel blocking effect. So, if calcium channel blockers and magnesium with its calcium channel blocking activity are able to work as antihypertensive agents, and they're working on the calcium balance inside the cell, this is a direct implication that shows that a state of calcium excess inside the cell must exist in the first place. So this is indirect but strong evidence that increased intracellular calcium is the root of all chronic degenerative diseases. So the positive effects of calcium channel blockers in any disease process, and like I said, it does a lot of things other than just anti-hypertensive, occurs because the disease cells always have increased intracellular levels of calcium. Now, these are just a few things that calcium channel blocker and magnesium administration show as benefits: coronary spasm, vascular tone, anti-atherosclerosis, pulmonary hypertension, vascular tone, Raynaud's phenomenon, vasoconstriction, acute head trauma, epilepsy, neuropathy, Alzheimer's and Parkinson's, osteoporosis. So point being is a lot of these things are vasospastic, but even the ones that aren't vasospastic, they're still precipitated and sustained by excess intracellular calcium, and taking the measures to lower it or block it give positive therapeutic impact on this incredibly diverse array of diseases. Now, calcium channel blocker effects, which means you're lowering the calcium, and similarly, if you take magnesium, calcium channel blockers prevent the neurologic damage from methylmercury, which means they're preventing the oxidative stress. Here's a good one too. We said increased calcium involves all diseases. If that's the case, then decreasing intracellular calcium should positively impact all diseases, and that's exactly the case. Calcium channel blockers, in this case, it's important to note long-acting calcium channel blockers, decrease all-cause mortality. They decrease your chance of dying from anything. Also, the more you block calcium, the more you block cancer. And calcium channel blockers also decrease iron accumulation, interestingly enough, which is a factor in malignant transformation. So increased oxidative stress, calcium comes in by too much intake, very commonly from too much mobilization from the bones. This is the case in osteoporosis. They talk about osteoporosis like it's a calcium deficiency. It's actually just the opposite. Yes, the osteoporotic bone has decreased calcium content, but because bone normally contains most of the calcium in the body, when you start to mobilize it, which is what happens in osteoporosis, you excrete some of it, but you redeposit a lot of it throughout the tissues of the body. So in osteoporosis, the bones have too little calcium, but the rest of the body has far too much. So osteoporosis is effectively a body-wide calcium excess syndrome, not a calcium deficient syndrome. Anyway, either way, and I'm not going to go into detail on this, taking calcium is not the way to address the calcium deficiency in the bone, because the calcium deficiency in the bone is a manifestation of a metabolic oxidative process that's literally burning up the bone and releasing the calcium. And trying to take calcium to reverse broken down bone is like trying to take the smoke that comes out of burning wood and put it back into the ashes to make normal wood again. It just doesn't work that way. You need many other things to bring the bone back. You need to stop the oxidative stress. And in conjunction with that and vitamin D, you can start to pull in the calcium you need to stop osteoporosis or even regenerate new bone. Now, because of this, the less antioxidants and magnesium you have, the more oxidative stress you have, and that means the more that the remaining healthy bone is in your body will start to oxidize and release calcium. Similarly, the effects of chronic infection and inflammation does this, and very significantly, again, deficiencies of regulatory hormones like testosterone, estrogen, and thyroid. Now, we see arterial calcification very commonly. Here we see it very common in young adults. Well, I'd call 45 a young adult, maybe early middle age, I guess. And we see ectopic calcifications commonly in patients with cancer? Well, cancer has some of the highest intracellular oxidative stress you'll find in any disease. When they looked very carefully with refined imaging, almost 100% of prostate cancer patients had prostatic calcifications. And so finally, this was an article in the New England Journal of Medicine back in, I believe, 1997. And this again is an expression of calcium excess or an expression of magnesium deficiency, depending on which side of the coin you want to look. And in a nutshell, it found that the women with the highest scores on bone density testing had an increased risk of developing breast cancer. Well, an increased bone density score is great unless you caused it by taking calcium. So if you just did something positive like take vitamin C and nothing else, or vitamin D and nothing else, and your bone density goes up, that means you're developing good bone. But when you take it just because you're taking a flood of calcium supplements, you ratchet up the bone density a little bit, but it's cosmetic only. It's not strong bone. Well, as it turns out, this then was an indication in the New England Journal of Medicine that calcium supplementation or deficient magnesium was a direct factor in causing breast cancer, because the ones with the highest bone density in this series of patients would be the ones that take the most calcium supplements. So they effectively poison themselves with the calcium. Another test that allows us to reflect not only calcium, but magnesium status in the body is the coronary artery calcium score. Now, I'm sure it's logical to you that if you're accumulating calcium in your coronary arteries, you're also accumulating it everywhere else in your body, because the same conditions are going to exist everywhere else as they are pretty much in the coronary artery. So it can be taken that the coronary artery calcium score is a primary indicator of generalized calcium status and not just the calcium status in the coronary artery. So they initially looked at this and found that an increased score, more calcium in the coronary artery, meant you had a greater chance of heart attack, and that's true. But when they examined it further, they found that increased coronary artery calcium, not surprisingly, since it reflects body-wide calcium status, that an increased coronary calcium score indicates an increase in all-cause mortality. With regard to malignancy, it's been shown that if you can remove calcium from the intracellular space, that's mostly experimental, you can decrease the metastatic capacity and sometimes bring a cancerous cell back to a normal phenotype. So that's how significant calcium is in cancer and other such diseases. This might make a little of us uneasy when we think of if we like to say drink a lot of milk, or we're certain that calcium supplement is good for us. The data will show, and does show, that calcium above the normal levels that you need, the more you take of calcium, the more you are taking a primary carcinogen. You can't develop cancer without elevated levels of calcium inside the cell. And when you take the calcium out, the cell becomes less malignant or non-malignant. So magnesium dissolves the calcium, blocks the calcium, increases intracellular calcium, and because of these effects, it is the primary anti-osteoporosis agent, not calcium. Magnesium as a monotherapy increases bone density and decreases fracture incidence, decreases all-cause mortality, and, very important, non-toxic at supplemented doses. You can definitely kill yourself if you take too much magnesium intravenously too rapidly. It's just a manifestation of the normal impact it has on the blood pressure. But for all intents and purposes, with supplementation, it's as non-toxic as it comes. Now, Magnesium and longevity. This is an important slide. Let me start by saying, in your clinical practices or in your own personal health habits, never miss the opportunity, if you or your patient are getting an IV for any reason at all, to add magnesium. You're just missing a wonderful therapeutic opportunity to get a substantial amount of magnesium inside the body, not have to deal with the minimal absorption that you get with oral forms or the diarrhea-inducing aspects of too much magnesium orally, just like too much vitamin C orally. And the reason why is in this slide. There were 2 studies that demonstrated a large one-time administration of intravenous magnesium reduced all-cause mortality for a period of as long as 5 years. So one intervention over, in this case, 1 or 2 days, still gave you a lesser chance of dying 5 years later, regardless of whatever else you did. This powerful one-time infusion of magnesium, in this case, a very high dose. One case, they gave 22 grams over 48 hours, so 500 milligrams an hour for 2 days. And another one gave about 1 gram an hour over a 24-hour period. So basically, 22 grams over 1 to 2 days intravenously decreased your chances of dying from all diseases up to 5 years later. And maybe longer. They just stopped measuring at 5 years. And I think I'll go into this later, but the reason why that is that, let me go back, is that less than 1% of magnesium is circulating in your blood. So when you get a magnesium blood level, this is just reflective of the magnesium in your blood and is really no reflection at all of how much magnesium you have inside your cells, unless the blood level is low. If the blood level is low, you know for sure the body level is low. But if the blood level is in the normal range, you may have a normal blood level, a body level, you may not. Most likely not, as I said before. The point is that 99% of magnesium in your body is inside the cells. And this is very important, something Dr. Selvum alluded to earlier when we started out about the importance of the mitochondria and energy. Of the 99% that's inside the cell, 95% of the magnesium is inside the mitochondria. So very clear that magnesium is a primary player, as we mentioned earlier, in the synthesis of ATP and glutathione and in keeping the cell optimally replete with energy. So some additional qualities of magnesium that I think are little appreciated. Magnesium is a healing agent, just magnesium. Okay, now when you're healing, you're normalizing a cell. Okay, a lot of research has shown that magnesium heals bone fractures and promotes bone growth. A lot of literature to show that it accelerates the quality of ulcer healing in diabetes and the rate at which the ulcers heal. Similarly, it accelerates burn healing, and all of this is due to the normalization of intracellular oxidative stress. Now, on clinical infectious syndromes, I know I've talked a lot to this group, both in Malaysia and online, and I think most of us are familiar with the work of Dr. Frederick Klenner, who found that when he treated acute polio cases, mostly in babies and young children, back in the 1940s, with IM and intravenous vitamin C, he was able to cure 60 out of 60 cases. And most of them took 3 days to resolve, and 3 of the 50 cases took, 60 cases took a full 5 days to resolve. but complete cures nevertheless in 100% of those patients. Well, amazingly enough, pretty much the same thing has been done with oral magnesium chloride as has been done with intravenous intramuscular vitamin C. Now that by itself is a pretty amazing statement in my opinion. I mean, for any oral agent to have the same impact of another agent intravenously. Of course, enough oral vitamin C would do the job with polio too. But the point being is, this Dr. Nouveau in France in the 40s treated 15 cases, 15 cases of polio, anywhere from a 20-month-old baby to a 47-year-old adult. And one case where it was acute, the polio was cured in 24 hours. And in many of the cases where it had gone on for 4 months, it resolved that as well. And for most of the cases, resolved paralysis that had been present for months already too. So this is the formula. This is a good thing to remember because it's probably only behind hydrogen peroxide, just about the cheapest thing that you can buy that's available around the world in most pharmacies, magnesium chloride salt. And you can mix it up with regular water and you can have a very, very, very potent immune supporting agent for pennies, okay, available to all. So keep that in mind. Interestingly enough, I don't have a slide on this, but I just want to tell you that although we see magnesium as a strong immune supporter and good for infections in general, we have to be very clear that this particular use of Dr. Nouveau was with magnesium chloride. And the anion is important in this case, as is the cation. For example, sodium chloride, table salt, has an antibacterial action. You get a little sore throat, you gargle with salt water, that can sometimes help quite a bit. Well, it's the chloride in magnesium that's very important as well. In one study, an in vitro study, looking at the growth of a particular virus, they found that magnesium chloride knocked it out, but magnesium sulfate promoted the viral growth. Okay, so when you're thinking about therapeutics for viruses and magnesium, think magnesium chloride first. And this is part of my suggested protocol for both preventing and resolving coronavirus, the COVID-19, along with some other interventions. With regard to hormones, two things all hormones do is they optimize and accelerate normal metabolism, and they minimize to normalize increased intracellular oxidative stress. The big ones, in my opinion, insulin, hydrocortisone, thyroid hormone, sex hormones. Interestingly enough, all of these have different unique ways, some different from others, in promoting magnesium, increased magnesium inside the cell and increased vitamin C inside the cell. So I think that's really the primary way in which these hormones positively impact body-wide health, is by the way that they impact intracellular levels of vitamin C and magnesium. So when you want to minimize oxidative stress, hormones are essential. Nobody is too old. Nobody that's worth treating, worth your time as a clinician treating, is not worthy of having at least some support of abnormally low hormone levels. Doesn't mean you need to bring them back to high normal, but you're treating an old heart patient, 85 years old, and he's got a really low testosterone, start testosterone. Don't start a lot, start a little, but that has a powerful impact. Elimination of focal infections, optimizing magnesium, digestion, supplementation. Estrogen, Look what estrogen does. Calcium channel blocker, which also raises magnesium, and has been shown in a separate study by itself to increase intracellular magnesium levels. Also, it promotes magnesium levels by minimizing its elimination in the urine. And not surprisingly, if it's blocking calcium, raising magnesium, it's anti-inflammatory. And not surprisingly, by itself, it decreases all-cause mortality. Testosterone is almost the same thing on the male side of the equation. Calcium channel blocker, lessen metabolic syndromes, decrease all-cause mortality. And insulin is a primary facilitator of magnesium uptake. Testosterone lessens insulin resistance, which facilitates magnesium uptake. Insulin, we've seen, and there's a lot of studies in this, even though most people haven't heard of them, and I never heard of them until I just poured through the literature of the research from a magnesium book, is in prospective, double-blind, placebo-controlled trials on massive numbers of patients, insulin has been shown to be a profound accelerator of healing, wound healing, okay? Horrible diabetic wounds, bed sores that just won't resolve. When you use protocols that use insulin, nearly all the time you start to initiate healing very promptly and very effectively. And even though these studies exist, I don't think there's a single wound center in the entire world that routinely uses insulin. Go figure. So it has been documented that insulin directly promotes magnesium uptake in the cell, directly promotes vitamin C uptake in the cell, directly conserves magnesium and doesn't waste it in the kidney. And in addition to all that, it has, of course, its ability to facilitate glucose uptake into the cell so that you can metabolize the glucose. When glucose is metabolized, that's also supporting a normal redox state inside the cell, allowing you to have, again, better magnesium and vitamin C levels in the cytoplasm. Hydrocortisone, this is almost a broken record. Powerful anti-inflammatory, calcium channel blocker, and it greatly enhances cellular vitamin C uptake. It's my opinion. Now I want to separate established fact from my opinion. It's my opinion. The primary role of hydrocortisone and the primary role of the immune system in general is to supply vitamin C to areas of acute inflammation and to push vitamin C inside the cells. The monocyte, which is the first cell to show up at an site of inflammation, which is a site of acute vitamin C depletion, is the monocyte, which has 80-fold, 8,000% more vitamin C inside it than the other cells, than the blood. So it appears to me, since vitamin C is what you need to quell inflammation and to neutralize increased oxidative stress and to restore vitamin C in an area where you're deficient, along comes the monocyte, the first cell in the immune response, and what's it doing? It's flooding the area with vitamin C. So I really consider, it's simplistic, I agree, but I consider the primary role of the immune system is to acutely supply vitamin C where it's most deficient in the body. Thyroid hormone, incredibly enough, is probably the most potent modulator of oxidative stress body-wide. Increases magnesium, decreases calcium, increases vitamin C. It's been known to normalize magnesium levels in hypothyroid animals. So the hypothyroid state has low magnesium, and you take the thyroid, it magically, the magnesium levels start to normalize. Very importantly, is the subclinical hypothyroidism strongly promotes body-wide oxidative stress, which, and this is important, low levels of hypothyroidism, cellular hypothyroidism, not thyroid glandular hypothyroidism, greatly facilitates the metastatic spread of focal infections, like infected teeth or tonsils seeding the coronary artery and causing heart attack, and by the same mechanism appears to be a likely powerful promoter of the metastatic spread of cancers. Remember, in cancer therapy, we sort of have this obsession, maybe understandably, with let's obliterate the cancer, let's make the cancer go away. Well, a lot of times making the cancer go away also knocks out much of your immune system, especially if it's with chemotherapy. There's a lot of cases, not only with focal infections, but with cancers, which in many ways you can consider to be an area of focal infection. When you normalize hormone function, especially the thyroid, completely normal, you keep focal infections focal, and you keep cancers focal and slow down or stop their growth. Most naturopathic or integrative medicine treaters of cancer will tell you they have many cancer patients that they haven't obliterated the cancer's still there, but it's been there for years. And you have somebody that comes in with a diagnosis of cancer, sometimes metastatic, and you do all these interventions, and you get the antioxidant levels up, you normalize the magnesium, you normalize the hormone function, they stop growing. They still keep the cancer, but they end up having a normal lifespan. They end up coexisting with their cancer. So it's very important in general in therapeutics is to try to normalize oxidative status. When you normalize oxidative status, a lot of good things happen, including stabilization of cancers and sometimes, of course, eradication of the cancer. And this applies to all the chronic degenerative diseases. They can all be stabilized. Sometimes when they've been present only a brief period of time, they can be reversed or cured. But for the most part, you're shooting for stabilization. You're shooting for management or elimination of symptoms and allowing somebody to live a normal lifespan with minimal to no symptomatology. Okay, so this is just a reiteration of what I said earlier. Broda Barnes with the thyroid work. This is the best evidence I know of that normal thyroid function keeps focal infections focal. Regular thyroid tests reflect the status of the thyroid in your thyroid gland, which, well, that's logical. Well, the problem is your clinical thyroid status has to do with how much T4 is being converted to T3 inside every cell of your body. So it's like you have a trillion or two mini thyroid glands throughout your body. So because of this, probably drive endocrinologists crazy to hear this, but hypothyroidism is a clinical diagnosis and a diagnosis based on specific blood tests, but including free T3 to reverse T3 ratio. So 15 to 20% of T3 is produced from T4 inside the thyroid gland, okay? But 85% is produced inside every cell of your body, which means when you're not converting T4 to T3, you're not maintaining a normal thyroid status. And what do they treat you with most of the time? Synthroid, which is T4. Well, if your primary thyroid problem is a conversion problem of T4 to T3, this doesn't solve the problem. And there's lots of people that end up getting T4 and their quote unquote regular thyroid tests start to normalize because they're looking at the thyroid gland and not the rest of the body. And they say, but doc, I still feel horrible. And the doc says, well, that's okay. The thyroid test is normal now. So you want to shoot for a ratio of 18 to 20 to 1 of T3 over reverse T3. Temperature is important. And symptom improvement, okay? This is just, and you can look at this at your leisure. I mean, I can supply anybody that wants these slides with an email, or I don't know, maybe that could be supplied to you by SAHAMM. So that's how you do the conversion. And remember then, when you're treating this, there's two things to treat. You need to try to give thyroid, which is T3 or whole thyroid supplement. And you have to try to identify what's causing the increased oxidative stress that's knocking these thyroid values out of whack, which is usually focal infection, sometimes chronic pathogen colonization. And sometimes, not always, when you can eliminate what's causing the increased oxidative stress, this will normalize all on its own. But a lot of people, this develops in as they get older. They've already had a little bit of, if you will, thyroid burnout for many years of toxicity. And then just getting rid of the oxidative stress doesn't bring thyroid level back to normal, and you'll still need to continue some thyroid supplementation indefinitely. And this is probably the rule rather than the exception. So, magnesium supplementation. Many forms exist, just a few: chloride, glycinate, gluconate, threonate. Chloride, again, is a very good and very simple form and has what appears to be superior anti-infectious and anti-pathogen properties than the other ones. Liposome encapsulated, from Live-On Labs, from Altrian in Europe. It's very, very effective at getting magnesium in far better, in my opinion, in my experience, than any other form. You can also get a lot of magnesium in transdermally, oil and creams. The oil, actually, it's not an oil, it's just a very concentrated solution of magnesium chloride. Nebulization can also bring magnesium into your system, and it can also bring magnesium directly to areas where it can deal with the pathogens that you might have in your throat and respiratory tract, and at the same time supply magnesium directly to the cells that are being affected by the infection. And there's some dissemination of the magnesium systemically as well, although the amount is relatively small. As this is what I mentioned before, 99% is intracellular, 95% in the mitochondria. Really, it's very difficult to know what your magnesium levels are. And if you have a normal blood magnesium level, the only way to know if you're really normal inside your cells is either with a biopsy, which you probably would avoid, and a sublingual cell test that correlates well with muscle biopsies. And this is the only place I know of to get it. So I don't know how practical that'll be for you here or in Malaysia, but you can do other things like the red blood cell magnesium, and that'll give you a better reflection than the blood test. But for all intents and purposes, don't back off on supplementation, because you're really not going to overdose on magnesium from an oral point of view. So find out what your bowel tolerance is and try to keep yourself close to that, and then use some of the more bioavailable forms of magnesium, glycinate and magnesium chloride, for example, and you'll stay pretty close to an optimal magnesium status. And this is interesting too. I think for all the reasons that we talk about, magnesium obviously, or I think obviously, is not an antioxidant. Okay, it's got no electrons to donate. But by virtue of what it does with calcium, is there's no molecule that has more antioxidant impact or antioxidant support. Going over that. So the question might come is, you know, we always try to think things of in terms of how natural are they, okay? And a lot of healthcare practitioners out there say, well, you know, a normal quality organic diet is going to take care of everything. Well, not when we're in a world where we have 100-fold more toxins than we did 60, 70, 80 years ago. Toxicity is increasing every day. Every toxin causes oxidation, and the only way for oxidation to be reversed is by electron donation from an antioxidant, which means the toxin debt must be paid. Okay, you can't have a ton of toxins or pro-oxidants and take in a relatively small amount of antioxidants from either good food or minimal supplementation and expect to have optimal clinical benefit. It's just not going to happen. So more specifically, let's look at this. Of course, we have more toxins in the air, food, and water. Modern food processing, quote unquote modern, depletes magnesium content in the food by roughly 80 to 90%. In non-organically raised fruits and vegetables by 20 to 30%. So you have to supplement. I mean, if you don't supplement, you are ignoring one of the major, most straightforward ways to support good health and to help restore good health. It's really that simple. Like I said, some magnesium is always better than none, so don't be frustrated by the fact that, well, I'm not really getting my magnesium levels as high as I know they need to be. That's no excuse for not trying to do what you can to get them as good as possible. Now, let's look at specific disorders. Vasoconstriction, I mentioned earlier. Coronary spasm is both caused and made worse by deficiency. Hypertension, same thing. Matter of fact, when you have pregnant women with preeclampsia, which is severely elevated blood pressure during pregnancy and during the time when you're delivering, how do they manage that? Intravenous magnesium, okay? Intravenous magnesium can take any blood pressure, no matter how astronomical, and you can dial it down to zero. Obviously, you don't want to, but that's the power of magnesium. You can find a magnesium dose that can take any blood pressure and bring it down to a fatal, immeasurable level. So it's the ultimate controller of blood pressure. As I mentioned before, migraine is almost completely a magnesium deficiency disease, eclampsia. Also a sort of, I would call it migraine variant, is they have something called the cerebral vasoconstriction syndrome. It was interesting because a friend of mine had this syndrome and called me about it at the identical time I was researching and writing about magnesium and migraine. And so I did a little more research and I said, my goodness, you need to be on super high doses of magnesium along with a good calcium channel blocker. And she did. And eventually it resolved and stayed resolved. I mean, it was so bad in her that she had a small subarachnoid hemorrhage, but it didn't cause long-term damage. Neurologic disorders, epilepsy and seizures. And if you review the literature, you won't see this anywhere. The literature would indicate by the studies that done that magnesium should be the first agent used in epilepsy and seizures. You see, you get a seizure when the intracellular calcium gets too high and results in electrical instability, which then at some point in time causes an abnormal electrical discharge and you get the seizure. And the thing that is most pertinent and most direct to acutely bring those calcium levels down is intravenous magnesium. And it's been documented that the affected neurons in both epilepsy and seizures accumulate intracellular calcium. Same thing with Alzheimer's. Cardiovascular disease, I mentioned metabolic syndrome, very profoundly useful in bringing down elevated blood sugars, elevated cholesterol, elevated LDL, and the associated high blood pressure. Really biggie on magnesium, cardiac arrhythmias. the half a dozen people, family included, and started getting extra beats, maybe atrial, maybe ventricular, or little rapid runs of heartbeat for the first time in their life. Started them immediately on magnesium and 100% resolution, at least with my limited experience. I'm not suggesting this is going to be 100% therapy for every time you find a patient like that. But most of the time, new onset arrhythmias are caused by a substantial magnesium deficiency. And the bad thing about it is if you don't recognize this early on and use magnesium to treat it, the arrhythmia becomes self-propagating. If you go into an atrial fibrillation, for example, and you don't convert it quick enough, over time, atrial function becomes impaired and the atriums start to enlarge. And once you have physical enlargement of these chambers, then you're never going to get back a normal heart rhythm. Okay, you need to maintain normal chamber size. Interestingly enough, even congestive heart failure is profoundly impacted by magnesium, and taking more magnesium clearly increases the contractility of the heart. Not normalizes it, but improves it. This, to me, is one of the most interesting things I came across. Toxin or poison neutralization by magnesium. I used to say that the Poison Control Center should be done away with, except to the degree that you take activated charcoal to neutralize any toxins that have been unabsorbed, and you start intravenous vitamin C. And that's still excellent advice, except for one thing. Many poisons kill you by increasing the QT interval so quickly that you go into a fatal arrhythmia long before you'll actually die from the systemic effects of the toxin. Well, vitamin C is not going to affect that QT interval. So the advice now is you start calcium and magnesium infusion, because the magnesium immediately starts to bring the QT interval down, preventing you from having a fatal arrhythmia, while at the same time the vitamin C can go throughout the body and reverse the oxidative damage that was done by the poisoning. So, but there's a lot of things, a lot of toxins that cause this increase in QT interval. And I don't think I have the study to show this, but I'd be willing to bet a bunch that the vast majority of acute toxic overdoses are the acute arrhythmias that are caused. So when you take magnesium in such a situation, the calcium channel blocking lowers the IOS, shortens the prolonged QT interval. At the same time, it's increasing the uptake of vitamin C into the cell. So there's another synergy between magnesium and calcium here in the acutely poisoned individual. And then, of course, at the same time, it supports the immune system. And magnesium, unlike vitamin C, even binds some toxins while they're still unabsorbed in the gut. So poisoned individuals, vitamin C and magnesium, both in substantial doses. And if that person can be saved, you'll save them. And this applies to any poisoning. Okay? Heavy metal, pesticide, venom, alcohol, any sort of intoxication that you could find. So now I'm not telling you to get drunk and then go get a vitamin C magnesium infusion and start driving right away. That's not the point of this, but it would probably work. Okay. We saw that one. Now this is another thing too, is after that work by Dr. Nouveau on polio and magnesium chloride, I looked and looked and looked, because there were a few comments, logically enough, that if magnesium chloride could do this to polio, it probably does a similar thing to all other viruses and many non-viral infections as well. Well, as I point out in this slide, there have been no carefully conducted clinical studies that I could find, but it does appear by the reports of people and clinicians that have used magnesium chloride that magnesium chloride does have a powerful non-specific impact on resolving infections of all variety. Nebulization, very important because it optimizes your gut function by largely stopping you from swallowing pathogens in areas of chronic pathogen colonization. Hydrogen peroxide, I've advocated as a cure, horrible four-letter word, nebulizing hydrogen peroxide for resolving COVID, resolving coronavirus. If you catch it early, it'll knock it out completely. If you're already symptomatic, it should knock it out completely, but should take a few days longer. If you're very advanced, you'll need something in addition, such as intravenous vitamin C or other pro-oxidant therapies like ozone or hydroxychloroquine and chloroquine. Don't believe any of this garbage that you might be exposed to. I don't know, but let me just make this perfectly clear for the purpose of COVID-19. Hydroxychloroquine cures COVID-19 almost 100% of the time in its early stages, okay? It's just horrible, at least in the United States, how this drug is being actively suppressed. And they're actually, in one case, firing a doctor from his job for just stating what she considered to be a clinically sound statement about the effect that hydroxychloroquine had on all of her patients. This is a very sad day in medicine, although I think most of us have known for a long time, without seeing it quite so flagrantly, that at least in the United States, and I'm sure around the rest of the world as well, agencies like the FDA and the DEA and the big pharmaceutical companies value one thing above everything else, and that's money. Hydrogen peroxide, vitamin C, these completely displace the enormous amount of money that is made with the prescription drugs. They have this remdesivir that they're coming out with. Well, guess what? The amount of hydrogen peroxide to cure an early case of COVID would cost you about 10 cents. Let's just say less than $1. For remdesivir, which is not going to cure it, you're going to spend $3,000 or $4,000 per dose. Okay, and that's just to shorten your hospitalization. So unless something can be manipulated to make a lot of money, so just please, I say this because it frustrates me. I did the same question for many years. Stop saying to yourself, if it's really good, they're going to use it. That's not true. So recap then. Number one, increased intracellular oxidative stress is the pathology common to all diseases, all medical conditions, and all infections. Number two, when enough vitamin C and magnesium get inside the cells, calcium levels normalize, increased intracellular oxidative stress is no longer present, normal amounts of glutathione are synthesized, and the cell is normal. You have many different ways to supplement vitamin C, many different ways to supplement magnesium, and as we say in number four, absolutely do not neglect the balancing of the sex hormones and thyroid. And number five, cannot be overemphasized. Focal infections and CPC, chronic pathogen colonization, must be identified and eliminated or minimized in their impact by the proper adjustment of hormones and thyroid function. Thank you.
Thank you very much, Thomas. May I ask you a few questions? And before that, I would like to say this about your lecture. This was a very blissful experience, Tom. Blissful experience in enhancing knowledge. Thank you very much. I'm sure I can speak on behalf of every participant here that this has been one of the most wonderful lectures we have had. Few questions. One is, you mentioned that magnesium by itself is not an antioxidant, but it helps to reduce the oxidized vitamin C inside the cells. Is it by pushing the calcium out, or is there any other mechanism?
Well, it appears the primary mechanism is by blocking the calcium channels. So you normally have a dynamic balance of influx and efflux, okay? Well, when you block the calcium channels and you keep new calcium from coming in, while the efflux channels are not affected, then then calcium naturally leaves the cell, and at the same time it's not coming in. So by this mechanism, it appears that magnesium directly impacts the calcium levels. There may be other mechanisms, but these are the ones that are established.
Okay. Another question is, there are different types of magnesium. Yeah, it is correct to say that, you know, these carriers have their own benefits, but ultimately what matters is how much of magnesium is getting into the cell. Am I right?
Yes, I mean, that's the ultimate goal, is how much of the magnesium gets absorbed. Let me say one thing, it wasn't in the lecture, but I want to be very precise when I say there's no significant toxicity with oral magnesium. There's probably one major exception to that, which is when you use magnesium as a cathartic, as a laxative, as is often done in nursing homes and facilities for taking care of the aged who are chronic, who are often very constipated and not going for days at a time. When you give a large amount of magnesium as a cathartic there and it doesn't work, it just sits there and gets absorbed rather than coming out. And under such circumstances where you're not inducing the cathartic effect and you've given a nursing home patient a large amount of magnesium, it ultimately does get absorbed and can cause toxicity and even death. In the same way that if you took a large amount of intravenous magnesium, you can bring your blood pressure down to 0 and die as well. But under normal circumstances of supplementation, regular ambulatory person, it's not a consideration.
So what matters is the rate of absorption.
I'm sorry, repeat?
What matters is the rate of absorption into the cell, right? Getting into the cell.
Well, there's I don't know what the exact percentages are. I mean, you have magnesium oxide, which is very poorly absorbed, yet they still have a lot of studies where they've shown that just taking 500 milligrams of magnesium oxide a day clearly had a powerful positive clinical effect. When you take something like magnesium glycinate, you get not only magnesium, but you get a good amino acid that you need in abundance called glycine. So taking magnesium chelates is always a good way to go too. Magnesium chloride is especially good, as I said, because it's very well absorbed and it appears to have more anti-pathogen properties because of the chloride. But how much is absorbed is really a very individual thing. So there's no way to, that's why the practical way to approach it is depending on your pocketbook, because some things are more expensive than others, availability. You find yourself a magnesium supplement and try to arrange a regimen where you take it several times a day. Try whatever means, you know, breakfast, lunch, dinner, whatever, that sort of thing. And that way, just like with vitamin C, you can take more over a 24-hour period without causing any sort of aggravation of the bowel, than if you can take in the whole dose all at once. I mean, most people, if they take 2 large teaspoons of vitamin C powder, they're going to have diarrhea in an hour. On the other hand, if they take half to 3/4 of a teaspoon 3 or 4 times a day, they get all that vitamin C in, and they don't get the bowel effect. I mean, remember, it's magnesium citrate, for example, that is deliberately used by the gastroenterologists to cause diarrhea and clean out the gut so that you can get a colonoscopy. So, I mean, you expect to get diarrhea when you take too much magnesium. That's not a side effect, that's an anticipated physiological effect.
One more question, Doc. Are there any specific magnesium transporters?
I believe there are, but I'm not sure. I will say this. We know for a fact that insulin strongly promotes magnesium uptake. So that would imply the use of a transporter system, but I don't want to misrepresent there, and I'll just say I'm not sure.
Oh, okay. Thank you. Thank you very much, Tom.
All right. Very good.
Sati, help the other questions.
Yes, we've got a question from Dr. Sankey. Dr. Sankey, would you like to ask him a question?
Yeah. Dr. Thomas, I would like to know what should be the ratio of calcium and magnesium when we mix in serum to treat fatigue when the people get weak, and then we want to restore the energy. We combine calcium and magnesium. So what should be the good ratio?
Well, there actually is an optimal ratio of calcium and magnesium in the blood. I must confess, I don't have it at the top of my head. It's like 3.8 or 4, but don't take that. I have that in my book, all the ratio that you shoot for. But that's the ratio in the blood. Let me repeat, don't take calcium, okay? Don't take calcium. You shouldn't be using, in my opinion, based on the evidence in my latest book and on the evidence in Death by Calcium, all extra calcium does is present more toxicity for the magnesium to counteract against, okay? So please just forget the idea of giving calcium in any form of supplement. I think I might have made this offer in the last time I talked to the group several weeks ago, but send me an email. I'll send you a link to get a free ebook of Death by Calcium. The magnesium book you have to buy. I don't have one to give away there, but those 2 books will give you the relationship between calcium, magnesium, and general health, and the clear-cut reasons why you should never, never, never supplement calcium. Yes, it's calcium.
Okay, next question from Ms. Poon.
Yes, Dr. Levy, I wanted to ask you about somebody with an eye stroke. What form of magnesium would work for somebody with quite an acute eye stroke?
Eye stroke?
Yes, a stroke in the eye, the congestion, constriction in the capillaries, supplying blood to the eyeball.
Okay.
So the person is blind.
You know, I'm not familiar with that condition per se, but as I mentioned earlier, magnesium is probably your most potent vasodilator available given intravenously. So just like you would with migraine or any other acute vasoconstriction syndrome, the eclampsia and preeclampsia, all of these things will respond. So what you did though there is I imagine if there's permanent damage, you're probably dealing with a blood clot as well as vasoconstriction. But if the primary insult is just vasoconstriction, I would think a magnesium infusion acutely would be one of your best ways to approach that. But all that said, let me just finish by saying I have no expertise with that particular condition.
Mm-hmm. But what form of magnesium? Because you mentioned Dr. Neville used magnesium sulfate. That's Epsom salt, right?
Yeah, no, the form that they use intravenously most commonly, you can use magnesium chloride, that's fine, but the ones that they've done most of the work on in the literature for vasospasm is magnesium sulfate.
Mm-hmm. Thank you.
Okay.
Next one is Dr. Maya.
Thank you, Ms. Sati.
Okay.
Dr. Levi, I need to ask about spasmophilia by a young adult with spasmophilia. Usually I give vitamin C and calcium, but now listening to your lecture, thank you for that. So I'm thinking how to balance it. Should we give magnesium? If yes, in which form? That is the first question. And the second question is regarding calcium. The testing, the laboratory in Indonesia, we are very limited. So we have only calcium ion, calcium, and calcium in urine. So how to check? Thank you.
Well, you don't need to check the calcium levels because anyone who has disease has calcium excess. It's a straightforward but very reliable clinical assumption / conclusion. We're not talking about calcium levels in the blood. We're talking about calcium, total calcium status in the body and inside the cells. So calcium blood levels aren't going to be reflective of this any more than magnesium levels are going to be reflected of your total body level of calcium. And Dr. Selvum, I had a little bit of bad connection with this individual. Can you tell me what the first question was?
Maya, what was the spasmophilia, is it?
Spasmophilia, Dr. Selvum. I have a patient, young adult male with spasmophilia, and I am giving, actually, to be very honest, calcium and vitamin C. But, you know, now hearing the lecture and reading the book from Dr. Thomas Levy, we know that we should not give. So I'm considering magnesium, but if we give magnesium, will it resolve the symptoms, and how is it, how to balance it? Besides hormonal as well. Thank you.
They say spasmophilia?
Yes, spasmophilia.
Okay. Well, that's the second new disease to me that I've heard today. Well, I tell you what, though, again, just like I mentioned earlier, if it's truly related to increased vascular tone, magnesium, in my opinion, should end up being the drug of choice, or the agent of choice for something like that. But I say that telling you I have no experience with that. And as you just summarized, definitely calcium and magnesium are the yin and the yang. So you give both of them, you end up not only neutralizing the benefits of the magnesium, you still end up increasing the total status of calcium in the body. So, but I'm not really familiar with that particular condition. So that's as best I can answer for you there.
Okay, thank you.
All right.
Okay, one more question from Dr. Liao Biting. Dr. Liao? Dr. Liao, are you there? Hello?
Now, can you hear me now?
Yes, but I think there's some...
May I know what is the optimum level of RBC magnesium that we should aim for? And is it a good idea to mix different forms of magnesium in a day?
Optimal level of?
Red blood cell magnesium.
Somebody needs to mute. There's a lot of noise coming in. Everybody needs to mute. I'm sorry. I had a bad connection. Please tell me one more time.
What is the optimum level of red blood cell magnesium that we should aim for?
I don't have the normal reference range in my head, but you want to hopefully reach whatever the high normal level is for your particular lab. That's what you'd want to shoot for. And that would be probably one of your practical ways to monitor it. But like I said, that would be best for making sure that your patient is not slipping into a more marked deficiency, because even if you have a high normal level in your red blood cell, that's still not a good reason to back off on whatever supplementation you're taking to maintain that. You're muted. You're muted. I can't hear you.
Okay, now?
There you go. Yeah.
Yeah. Is it a good idea to mix different form of magnesium?
Well, that's an interesting question. If you, again, I don't have all of this at the top of my head, but I cited like 10 or 11 different forms of magnesium in my book. And there's more than that, believe me. And each one had its own unique effects, different impact. Threonate goes more inside the brain. Glycinate supplies you with an important amino acid. A few of the other types have different impact on different physiological functions. So to the degree that you might want to have more of the one impact versus another, you could combine it. There's nothing wrong with it, but I wouldn't necessarily say that that would be required. But you know, that would be an interesting area of research, quite honestly, to look at giving combinations of different forms of magnesium. Very interesting thought.
Okay, thank you.
Thank you, Dr. Liao. Dr. Silva?
Thank you. Thank you, Dr. Kenzimi.
Thank you.
Yeah, Dr. Levy, thank you for your lecture. I have actually one question to ask. In Dr. Klenner's protocol, he says that if we give more than 60 grams IVC per day, anything more than 60 grams in a day, we need to give calcium gluconate. How is it like that?
You know, that's a good question. And I ran across the same thing that you're talking about. And Dr. Klenner described that some people would get a little shaky or this, that, or the other, and he called that a calcium deficiency. Now, what I've noticed, and I noticed what Dr. Honeyhackey has noticed with over 100,000 vitamin C administrations, we've never seen the potential, I think what Klenner called it was tetany, or muscle contraction and this sort of thing with any dose of vitamin C. But what you do find, and perhaps this is what Dr. Klenner was referring to, what you do find is when you give a lot of vitamin C, 50 grams, for example, and you infuse it fairly quickly, the body perceives the vitamin C, which is very akin to glucose, as a large glucose load, and the pancreas secretes insulin, and you can make yourself hypoglycemic. And when you get hypoglycemic, you get a little trembly, you get a little shaky, you look a little bit out of sorts. My hypothesis is Dr. Klenner was inducing a little bit of hypoglycemia and didn't realize it and just reached the conclusion that somehow it was affecting calcium. But we've never seen that. And I'm talking over 100,000 infusions. We've never seen that. And we've given many 75, 100, 125 gram infusions.
Okay. Yeah. Thank you. One more question. What about in the case of magnesium, in the case of end-stage renal failure, Dr. Thomas?
Well, just like anything else, you need to, you can't be as indiscriminate in your dosing, but especially if you have, as I mentioned earlier, a documented low magnesium level, that always indicates deficiency. And so in the case of the renal failure patient, you would definitely want to give some supplementation to at least bring them into the quote unquote range of normal or reference range, but you'd have to be careful about pushing the dose much further.
Okay, thank you, Dr. Levy.
Sure.
Okay, next question from Dr. Nafdi.
Hello, Dr. Levy. Is it important to know the amount of elemental magnesium in different magnesium forms?
Well, it's important in, I guess it'll put this way, it's an important piece of information, really, if you're doing a clinical study, because you want to reach conclusions based on precise amounts of X, Y, and Z and what was given in a protocol. Practically speaking, this may sound simplistic, but practically speaking, you want to take the amount of magnesium that you can easily tolerate. So, as I said before, a normal person taking oral magnesium and is not taking large amounts of it to cause bowel evacuation, you're not going to overdose on it, and you're just going to get closer to your optimal dose. So in terms of your own clinical situation, it's not a practical piece of information, but if you want to compare different magnesium supplements, it's a useful piece of information.
All right. Okay. My second question, is it true that magnesium glycinate can help to reduce glyphosate toxicity?
I don't know specifically on that, although I will tell you, we discussed earlier how magnesium helps reverse the toxicity of anything. And all toxins work by the same final common denominator mechanism. So although I'm not aware of the study or whatever, in particular with magnesium glycinate and glyphosate, it would not surprise me. That sounds very logical, and I would think that that was a true outcome.
Okay, thank you very much.
Sure.
Anyone else have got questions?
Yes. Can I have a question?
Okay, Mr. Sofyan.
Yes, thank you. Does it true that if we maintain our insulin level a bit too low, then it will deplete our magnesium levels? And if it's true, what's the reasons behind that? Thanks, Doc.
Well, as I mentioned during the presentation, insulin, one of the main effects, believe it or not, along with its effects on glucose, one of the main physiological properties of insulin, and I think this is a large reason as to why insulin is so effective in helping healing, is it pulls or pushes magnesium directly into the cell. So presumably, if your insulin levels are chronically low, it would follow that you're effectively getting less magnesium into your intracellular space.
Okay, thanks. Thanks a lot.
Sure. Okay.
Hi, Dr. Levy. My name is Dr. Balji. Could I ask you 2 questions, please?
All right, shoot.
Thank you. I'm asking for your opinion, Dr. Levy, and your practice. If we draw blood for red blood cell magnesium, is it important, or does it make a difference whether we put a tourniquet or we do not put a tourniquet for red blood cell magnesium?
I don't think that matters. I mean, not as a practical point. I mean, there may be some minimal effect, but not any significant effect. No.
Thank you. Second question: if we start a patient on a calcium channel blocker, and we note that there is a long lag time before they respond in terms of blood pressure reduction, or in our history taking, we get a new patient and we notice that he's on a big dose of a calcium channel blocker, could we draw a rough conclusion that the higher the dose required to bring the blood pressure under control, or the longer the lag time between starting a calcium channel blocker and response, indicates a worsening in terms of his overall health, in terms of disease?
Yes, because I think that's a direct indication that your intracellular calcium levels are even higher than in someone else. I mean, as I mentioned earlier, the reason calcium channel blockers affect blood pressure is because there's a calcium excess, and if it takes a longer time and a higher dose of calcium channel blocker to get a positive clinical effect, that directly implies a more substantial calcium excess in the cells. Yes, sir.
Thank you so much.
If there's no more questions, we can end the session for today. Is there any more questions from anyone? Okay, that's all I think.
Okay.
Yeah, that's the end. Doctor, you'll have to unmute.
I'm sorry, what?
Yeah. Okay. Thank you very much, Tom.
All
Thank
right.
you. Wonderful.
Thank
Take
you,
care.
Dr.
We'll love
Thomas.
to have you back
All
again.
right.
See you.
Bye-bye.
Have a nice day.
You too.
Thank you, everyone.
everyone.
And we'll have it your next Saturday, 8 p.m. Sati.
Yes, next Saturday.
Okay,
Next Saturday is at, no, 7. Your time. You are presenting after Dr. Patna. It's at 7. Yours is on the 22nd. Dr. Patna will be next week, Saturday at 7 p.m.
Okay.
Yes. Indonesian time is 6 and Cambodian time is 6 as well.
Okay. Thank you. Good night, everyone.
Thank you all.
Thank you, Doc. Thank you.
Good night.
Bye.
Thank you.